group problem solving session. So I think everyone is now back. Welcome back. What you did there for 10 minutes is a warm-up for what you will be doing the next time we go into the itch session of breakout groups. Next time, you will have to designate a rapporteur, a note taker, someone from your group, from your breakout group. It should be the same group unless you get disconnected. Will have to take it upon themselves to take notes and then submit those notes on behalf of the group. That is how your attendance will be recorded, your attendance as well as your participation. So now we are going to work through together in plenary from challenge identification to action planning to improve VPD surveillance systems. The first concrete case we'll be working on is the one from Safa. So it looks like, unfortunately, Safa is not in the room with us. Charlotte, can you confirm?
Yeah, Safa is not in the room, Reda.
All right. So let's see. We obviously won't be able to get answers, but let us start with Safa and this example from Sierra Leone. So Safa Kamara works at the national central level and says there are various vertical programs in the Ministry of Health, each with specific mandates, intervention areas. Most of the programs have disease surveillance components that are implemented in silos. Efforts should be coordinated to maximize available resources for cost effectiveness. All programs and partners should work together and ensure resources are mapped and activities implemented inclusively. The challenge is that partners and government agencies are not coordinating, hence duplication of efforts and resources. So the point about this case is to ask everyone in the room now to consider Safa Kamara's challenge and to think about your own experience. Is this challenge a challenge that you face? Is this a challenge where you have been able to make progress? If so, we'd like to know how. If so, we'd like to invite you to share your experience. And then, of course, we'll be turning to Anna Minta and Anindya Sikar-Bose from WHO for their insights and experience. So let's see. We have Herbert, who's the first to raise their hands. Herbert, over to you. And then we have Alain Blaise Tatsinku. So let's hear. And then Pamela Oben. So, great. So we'll listen to Herbert, then Alain Blaise, then Pamela, and then we'll turn to Anna and India. Herbert, when you read Safa Kamara's challenge, is this something that you are familiar with? Is this something that you are facing too? Please do introduce yourself first, though. Yes.
Ministry Surveillance Officer, one of the regions in Uganda. Yeah, according to this challenge, in most countries, I've worked in most countries, I've worked in Asia, in Africa, but the main challenge is countries don't own surveillance. Most of the surveillance is done by partners, and these partners are independent, and it's very hard to coordinate them. And mainly, like in most countries, it is WHO and the UNICEF, but other partners come in and they don't even show up. So it's a very great challenge to countries. Even in Africa, even in Uganda, where I work, you cannot ask who is in charge of surveillance at the Ministry of Health. You can't. It is only WHO and UNICEF.
Yes, so it sounds like
it's a very great challenge in almost many countries where surveillance is being done of VPD. Thank you.
All right, thank you, Herbert. So can you tell us something you did in the past, something in your experience that helped to overcome this challenge, where you were able to get partners and government agencies to coordinate better, to avoid duplication of effort and resources? Have you been able to make any progress that you'd like to share from your experience?
Yes, I have been able to solve this challenge in my region. I have called on partners, mainly USAID funded projects. They have been supporting surveillance, and UNICEF partners. We sit down and plan in terms of surveillance and how to support VPD surveillance. So far, we coordinate to each other and we make one report, which is submitted to the Ministry of Health. So at least we are moving on well. Thank you.
All right, thank you. Now, the next person was Pamela Oben. Pamela, you were the second person to raise your hand. Sometimes we can't keep track and we don't necessarily follow the order. But Pamela, I would love to hear from you. This Safa Camara's challenge from Sierra Leone, is this a challenge you face? Do introduce yourself, tell us who you are, where you work, and then what are your thoughts on this and your experience?
Hi, everyone. Hi, Reda. I'm Oben Pamela, and I am the EPI coordinator for the Southwest region in my country, Cameroon. I want to join my voice to Safa and the others just to say, yes, it is a challenge that is very true to us in the fact that not being able to coordinate surveillance activities has been a major challenge. We have the integrated disease surveillance response, and we have VPDs in my region. And there are times when samples collected maybe for monkeypox, they don't have forms. They don't have particular forms for notification of monkeypox. And we had this particular situation in which a measles form was used to notify monkeypox, and it ended up coming to our specimen collection center. And in some ways, it was forwarded together with our samples, and we see how this is already a challenge as it was being tested. It was tested then for measles and not for monkeypox, just because they didn't have the particular tool. So being able to work together, coordinate activities together is very important. We use this as a stepping stone to work with those in charge of the integrated disease surveillance response, and just to let them to be clear on the channeling, the courier channeling system for specimens. And also it's an opportunity, it was used as an opportunity to work in collaboration with them to know which cases are being notified at the level of the health district and to ensure that the channels followed are appropriate. And we don't get to have such a situation anymore. So yes, coordination is very important, and we can only work well when we work in collaboration. Thank you.
Thank you very much indeed, Pamela Oben from Cameroon. Let's go to Alain Blaise Tatsinku. Alain Blaise, okay, his hand is now down, but let's, Alain Blaise, please, what is the experience you'd like to share in response to Safa Camara's situation case?
Yes, Brenda, thank you very much, and good morning, everyone. Thank you, Camara, for sharing this. And I would like to especially thank Minta for her introduction, and Godwin and all that. This is really a critical point. What I want to share here is really an experience coming from the challenges that we faced in Haiti a couple of years ago. The country being in the after the earthquake, to be able to demonstrate that we still have the elimination of measles. So we budgeted and put in place a team of surveillance officers. Well, back then I was a STOP team member, and we developed the national network of surveillance officers within the country. And as you all know, the country was also facing the cholera outbreak, a major challenge. And we were able to really use the resources that we as VPD surveillance officer put in place to also support the cholera outbreak, from the surveillance, the active surveillance, to the response when the vaccines were available at the country level. And that was really a critical point to help the country achieve not only the certification of being measles-free, but also that was a major turning point to tackle back the cholera in the country. And the VPD surveillance was the entry point where we were able to leverage resources in place to help the country tackle the challenges as a whole in an integrated manner. So I would like to seize the opportunity to really thank those VPD surveillance officers who were able to also help the country to be cholera-free. That is what I wanted to share here. So Kamara's point is really critical, and we really want to, all of us here, to reflect back on how we can leverage existing resources, local resources, to achieve what we are doing, because resources is key, but where are they coming from? And that is where I would like the discussion to go back to how to leverage mobilize local resources for VPD surveillance and not waiting only external partners. Thank you, Reda and team.
Thank you, Alain Blaise Atsinku. Let's go to Anna Minta now for feedback on this case and what we've heard from course participants so far. One point of note is now Safa is not in the room. We still selected this case for discussion. Safa will discover what we said afterwards, but the point is to help Safa Camara facing this issue. What, in your experience, has actually been effective in overcoming such a challenge? And for Anna Minta, the corollary question is, how can the new global strategy help someone like Safa Camara or others facing this quite common issue to think through what specific steps to take to tackle this challenge?
Thank you. Thank you, Safa, for the question, and thank you to those who have answered so far. This has been a very great discussion. I'm glad to hear about some of the success stories that you mentioned about how you were able to integrate the different funding streams, resources that were available. I think this is a huge challenge. I've seen some comments in the chat as well about why it's a challenge. It can start from who is funding which disease. I understand that. I've worked in malaria, HIV, TB, and vaccine-preventable diseases, and it's usually completely different funders. So when you're starting from there, it can be in silos and very difficult to work across. But I did see one common thread among the comments that have been mentioned so far is that someone took the initiative to reach out to someone in another program and convince them maybe of how it would be helpful for everyone if the resources were used for more than just their disease of interest. So I think that's very important. And then Alain also mentioned that it can be difficult if the country waits for external partners to initiate this conversation. And that's one of the very important points from the global strategy, is that we want surveillance to be country owned. So if the country is finding that the external partners giving their funding in silos is leading to duplication, and then some things are also falling through the cracks, it can be some people from the country who can talk to them. And I'm not saying it will be an easy conversation or that it will always work, but to initiate the conversation that in our country context, we think that it would be helpful if we could use the resources from COVID for measles or, whatever the case may be in your country setting. So these are very good points, and there should be definitely more conversation about how to address this.
Great, thank you, Anna. Let's now look at the second case. And for participants, you all have the slide deck. You know that there are many more such cases, and the point of sharing them with you is for you to think about. For Samuel Luca Abbott, what would be your advice? And let's see if Charlotte, are you able to tell me if he is? Yes, Samuel is here. I know he had. I believe he was one of the folks who had connectivity issues. We'll see if we can hear from him first. So he works at the national level in Nigeria and says basically surveillance is funded by government partners with little or no funding from the government. Efforts at getting government ownership of surveillance activities, especially at the subnational level, remain a big challenge. There have been engagements in terms of advocacy and sensitization for the need for government at the subnational level to provide leadership and funding to improve surveillance for VPDs, but it seems a huge task. I will be glad to get suggestions on how to deal with this issue. Of course, the Nigerian context is quite specific, but let's hear now if we can. So if you only keep your hand raised, or raise your hand if you'd like to share your specific experience with how something that you did in your experience that helped you, in your country to have government ownership of surveillance activities at the subnational levels. So I believe Mohammed Imran Qureshi is the first one up. Imran, you're calling in, of course, from Pakistan. Do remind us who you are and where you work. I know also you are not in a location with good connectivity. So, and again, on this issue of government ownership of surveillance activities at the subnational level, if you'd like to raise your hand, and I see contributions in the chat. So, but I'm not sure, Mersha Gorfu, which challenge you're referring to. They are similar. There's definitely some overlap in terms of the role of partners versus the role of government. Let's go then to Anna Minta. I don't see any hands up right now, so please do raise your hand if you'd like to contribute your specific experience, something, and then we'll hear from Samuel on this issue. Eric, Maita, you have your hand raised. How have you, in your context, been able to get subnational buy-in or ownership? And I'm also asking Samuel Abbott to unmute. All right, Eric.
Okay.
Please
yeah,
do
thank you very much. Yeah, thank you very much. I hope you can hear me.
Yes, loud and clear.
Thank you very much. So I just want to share my experience having worked at the sub-regional level. The issue of underfunding is across board. That some national government, sub-national government do not attach much importance to surveillance. But what we have done at the regional level is that during the budgeting process, where we budget all health activities and then they are subjected to the county assembly for approval, we do what is called program-based budgeting. So in the program-based budgeting, we have about 4 programs: preventive promotive program. Then under preventive promotive program, we have sub-programs. So disease surveillance is one of the sub-programs where we are supposed to come up with activities and budgeting. So in that sub-program, we budget issues of advocacy, issues of sample collection and transportation, and issues of quarterly review, quarterly surveillance review, so that those are funded. So when the budget has been approved, then those funds are available for us to use at the sub-national level. So though the funds are not adequate, but at least it is substantial to ensure that those activities that are budgeted for are implemented. Otherwise, we normally get much support from partners, from WHO and other partners. But the regional level, that is the much that we can get. For example, in the last financial year, we were able to be allocated around Kenya shillings 500,000. So Kenya shillings 500,000, I think it's just like, I think 50 US dollars. So thank you very much, and over and out.
Thank you, Eric. Maita, let's hear one more. Let's go to Dr. Martin Mayen. Martin, would love to hear from you. What is your specific experience? Do introduce yourself, of course, but what's the specific experience that you'd like to share that could be helpful to Samuel, whose challenge is how to get government ownership at the subnational level for surveillance activities? Martin, your microphone is unmuted, but I at least am not hearing you. Charlotte, can you confirm?
I'm not hearing him either, Brenda.
Let's go to Samuel Gia while Martin sorts out his connectivity issues. Samuel, please do introduce yourself and tell us what is your specific experience you'd like to share that could help Samuel think through the actions, the corrective actions to take to strengthen government ownership at the subnational level for surveillance activities.
Thank you. Good morning. My name is Samuel Gia. I work as Director of Disease Control at a subnational level in Nigeria. I think Samuel has a very critical point, and I like what Eric said. I think we need to, he has already started some of the solutions, which is advocacy and also sensitization. Because if that must be continuous until you achieve a reasonable ownership. And what do I mean by that? Budgets are made by governments and especially at subnational level, but they never get released, fund backings. Program officers make budgets, submit them, but at the end of the year, They just get maybe a percentage of what has been made. So, but for us in Nigeria, we are beginning to explore the option of bringing all the sub-national leadership, that is the governors, together in the Nigerian Governors Forum. And there we discuss issues that are critical to health. We talk about service delivery. We talk about funding for health. We talk about, now we're beginning to talk about even the surveillance that, look, in the government, you need to take responsibility because it's seen basically, just like somebody said, oh, it's WHO's program, it's WHO's work, it's WHO's role. If you have any issue, why don't you go meet WHO? So we need to begin to integrate them into that. Look, with WHO, yes, they work there, but they are partners to help us achieve our goal. It is our country, it is our state, it's our district. We need to do this. So advocacy and sensitization is a key role he needs to continue to do. Though it may be difficult, yeah, it took us time. It took us almost 3 years to almost get to the round table with them, but it just keep trying. Just keep trying. So thank you. I just want others to come in as well. You're welcome.
All right, thank you very much. Brenda, Harriet Ninsima, I've asked Brenda to unmute, but she is not responding. So
no, I have unmuted.
Okay, wonderful. Do introduce yourself, remind us who you are, where you're connecting from, and then what's the specific experience you'd like to share with Samuel Luka Abbott?
My name is Brenda Harriet Ninsima. I'm connecting from Uganda, and I'm serving at sub-national level, supporting polio surge activities, measuring surveillance and other associated activities. My experience is not indifferent from colleagues, more so about the different partners involved in surveillance. And this was recognized at regional level, because this is where I serve. And I am attached to a regional referral hospital. So regional referral hospitals have got a community health department, and the main mandate of this department is to coordinate community health activities where surveillance lies. So I proposed to the head of department, community health, to call on a meeting for the known partners between the district and majorly this was myself working for WALIM with support from World Health Organization, and then the World Health Organization consultant whose terms of reference were majorly into response to COVID. So my terms of reference were more directed to polio surge, and his terms of reference were to COVID response. So with those meetings, we were able to share our terms of reference and our district base, because we're in different district bases. We did zoning, and we were able to cover ourselves. So I covered polio, COVID activities in my district where I was supporting. He also covered polio surge in the district where he was. However, the challenge remained with the other consultants that would come in, like the end-stop consultants would come in for a short time. We could find ourselves in the same district offering the same services, which I would say would bring in duplication, bring in maybe even confusion to the district. So my recommendation would be that if all this is coordinated at Ministry of Health, and then Ministry of Health passes communication to the regional referral, which after goes to the community health department of the region, and the community health department at regional level takes up the mantle to coordinate this. However, this department is also affected by shortage of funds. And what we've been working on is integrating surveillance activities into planning for the regional referral. And for this financial year, successfully submitted a work plan to the budget of the regional referral. Over to you, Chair. Thank you very much.
Thank you very much indeed. Let's go now to Anna Minta. You've heard several contributions in response to Samuel Luka Abbott's challenge. Can you help us connect the dots back to the global strategy and also share your insights, comments, follow-up questions on this particular case?
Yes, thank you all for your feedback. I think you all have given wonderful examples that basically are in line with the comprehensive VPD surveillance strategy. I mentioned a little bit before, part of the strategy is for surveillance to be country owned. And what I'm hearing from you all is that it is really at the sometimes subnational or national level where you all are putting forth conversations. And I really like what Samuel said. It took 3 years. So like I said, this is not like we have the conversation one time and everything is solved. This may take some persistence, finding the right people to talk to. I've seen comments about turnover in staff, so it may be an ongoing conversation with every new staff that comes in. But the examples that you've given address that question and are definitely in line with the strategy. So thank you.
All right, thank you. Anna, we actually have 3 minutes left in this segment. There's some wonderful messages in the chat. Anna, is there anything that you've spotted that you'd like to bring to the attention of the group?
I did see a comment about performance-based financing. I don't necessarily am supportive of one particular type of financing. That's really at the country level and subnational level to decide how to do that. But I just wanted to say I like the idea, and I think it's helpful to think about supporting the staff who do surveillance, because it's a lot of work. They're asked to do so many activities. A lot of staff in many countries are stretched thin. And it can sound like when we start talking about comprehensive VPD surveillance that we're asking the same staff to do more work without necessarily more support. And so I just appreciate that comment about ways to support staff and provide some extra support for them as they do their job.